Welcome to Health Matters. We're so thankful you're here. So my name's Steve Smith. I'm on the Stanford Community Health Council. I'm so thankful that you're all here today. Before we get started, just a reminder that you can submit questions. And our goal today is to deliver actionable advice to you. And so please put your questions in. You can either go to the QR code that's on the screen in your program. And for those of you online, it's also on your screen there. And we'll get to the Q&A in just a moment. I'll ask Dr. Wu a couple of questions to start with, but it's my pleasure to introduce Dr. Joseph Wu. He's the director of the Stanford Cardiology Institute. He's also a professor of medicine in the Department of Cardiology and is also professor of radiology. But his resume is very long, of course, but I'm also super excited to tell you that we have the president of the American Heart Association with us today. Welcome, Dr. Wu. Wow. We are so lucky. So we'll be talking about many ways to improve your current cardio health, but also what you can do for the future also. So we'll be covering both of those. Usually we get advice to do the three main things, right? Exercise, eat well, and also get enough sleep. But we want to delve into maybe some of the other things that we can do too. Just a reminder, ask questions, put them in the queue, and we'll get to those in just a couple minutes. So first of all, Dr. Wu, welcome and thank you for being here. The AHA recommends several things that we do to practice that helps our heart health. The three basics, as we said before, are exercise, sleep, and good eating habits. Can we just start off today by just mentioning what your thoughts are in terms of actionable advice for our audience?
Yeah, so first of all, it's great to be here. And I also want to thank Steve for being my co-moderator. For those of you who don't know, when I was a kid, I wanted to be an astronaut. And sitting next to a real astronaut is really, really inspiring. And so thank you so much, Steve, for all the great work that you're doing for the Stanford medicine community. Thank you.
My pleasure.
And so Steve asked about some of the things that we could do in terms of cutting down your risk of heart disease. And I think all of you will know you start with diet, right? In a healthy diet, exercise, quit smoking if you're smoking. There's zero benefit of smoking. And then the other one is what Steve has mentioned is sleep. And it turns out sleep is very, very important. And the AHA just put sleep as one of the life's essential 8. It used to be essential 7 things that we care about. Now it's added as the 8th component. And that is our recommendation is that you get about 7 to 9 hours of sleep. It's important because when you're sleeping, I think as Dr. Frank Longo also kind of mentioned this, when you're sleeping, your body is repairing yourself. Your heart is repairing yourself. Your brain is repairing yourself. Pretty much the entire all the organs are repairing itself. And so having enough sleep gives your body time to rest. And I think all of you have gone through periods in which, for example, you take a red eye or you take a long flight and you go to a completely different zone. And the next day you wake up, you're completely kind of like out of whack. And that happens. That's basically your body telling you that the time zone is different. You're not getting enough sleep. All of us can have no food for 7 days. And we'll get skinnier. But none of us can have no sleep for 7 days, right? And that tells you how important sleep is. And so I would really encourage all of you to have a good sleep habit. So those are the 4 things that are modifiable, exercise, sleeping, smoking, right? And then your diet. The other 4 things that we ask our patient every time when I see a patient in our clinic is, what is your cholesterol level, right? In that case, we're asking to see what is your LDL level. We're asking whether you have a history of hypertension. In that case, we're trying to make sure your blood pressure is maintained about 120 to 80. We're also asking whether you have a history of diabetes. And in that case, we're trying to make sure that your glucose is not high because having chronic high glucose level causes a whole bunch of problems. And more recently, we're actually including BMI, the body mass index. 25 and above is considered overweight. Above 30 is considered obese. And so if you are obese, it causes hypertension, it causes diabetes, it causes high cholesterol. And so it's all tied together. So 4 disease conditions and 4 modifiable lifestyle conditions that you can tackle. Yeah.
Fantastic, great. And then would you adjust your comments if someone has a history of heart disease in their family, and in particular, are calcium scores important or advisable?
Yeah, so we don't have an official recommendation on the calcium score, but in general, if you're very, very low risk, let's say, for example, if you're less than 40 years old, we don't really recommend getting a calcium score. If you're a high risk, that means you're already a cardiology patient, you already had heart attacks before, we also don't recommend a calcium score. It's really in between. Let's say, for example, age 40 to age 75. And if you calculate, there's a calculator that you can look up on the AHA website to see what your risk is. And if the risk is somewhere between 7 to 20% of developing heart disease over the next 10 years, in that case, a calcium score plays a role. And so you could get your calcium score to see what it is. And for calcium score, for those of you who don't know, it's essentially a CT scan. You undergo a CT scan. It's very fast. It takes really seconds to get the image done. It tells you where the calciums are and the calcium deposits. More calcium deposits are associated with higher risk of developing coronary artery disease. And so if you have positive calcium score, you need to talk to your doctor about some of the modifiable risk factor I mentioned. And also if you have high cholesterol, we recommend taking medications to get the cholesterol down. Yeah.
Great. Well, let's continue and then talking about cholesterol. Can you remind us with practical words, what is LDL? What's HDL? Is the ratio important? What can we do about our cholesterol levels?
Yeah. So that's a very important question. So LDL is bad cholesterol, and HDL is good cholesterol. And so what happens is your body, your liver, synthesizes the cholesterol. And so if your cholesterol is way too high, these cholesterol kind of deposits on your artery. And if it deposits on the artery, it basically can plug up the artery. And especially the heart, if there's too much deposits in the heart, it can cause a heart attack. So just think of a pipe and the plumbing system. And over time, the plumbing system has kind of clogged up, has a lot of junk on it. And it's basically those kind of junk that we need to get rid of. And so you could take there's many medications that we give, but one of the medications we commonly give is called statin. It essentially is a drug that blocks the liver from synthesizing cholesterol. So if it blocks the liver from synthesizing the cholesterol, more of the circulating cholesterol then gets sucked up by the liver. And so it's very, very effective. I take it myself. I take Lipitor, 10 milligrams once a day, atorvastatin. I actually think it should be in the drinking water because it's how effective it is. And so I would suggest that if you have risk factors and if you have high cholesterol, definitely take statin. Yeah.
Great. Well, on the statin, I raised my hand when you said you take it because I have taken it for 10 years also.
Yeah.
And in the United States Astronaut Corps, our doctors think that everybody in America should take it.
Yeah.
So they've told me before. Yeah. I'm not suggesting that. Yeah. Listen to the expert.
Yeah.
But in any case, is there any alternative to a statin?
Yes. There are alternatives to statin. One is really lifestyle management. The doctors will always tell you to do exercise. I tried that 10 years ago. I tried to exercise and I tried to do a lot of things to get my LDL low, but it just wasn't budging that much. And I also had low HDL, the good cholesterol. It wasn't budging that much. And I had high triglyceride because I inherited from my mom. She had fatty liver. And it wasn't budging that much when I was exercising quite a bit. And I just decided to take statin, and the numbers just came down. But besides the exercise, if you have high triglyceride, there's a fibrates that we can give you, and these are drugs that decrease your triglyceride. If you have what we call genetic hypercholesterolemia, genetic hypercholesterolemia means you were born with some type of mutation that caused your LDL to be like 300, 400, 500. And even with the statin, we're having a hard time getting it down. There's something called PCSK9 drug that we can also give to you to dramatically get the cholesterol down as well.
On that same subject, our previous speaker talked about statin and its effect potentially on cognitive health.
Yeah.
How about the side effects in terms of the rest of our body? I've heard about muscle soreness.
Yeah.
And sometimes we hear that there might be a long-term bad effect on,
Yeah.
is it on the liver or
Yeah,
what are your thoughts?
so in general, statins are very, very safe. And I rarely see somebody comes in with liver toxicity. And essentially, the liver toxicity that we really care about, and which is really, really high, that we have to stop the medication, is about 1%. In terms of the muscle pain, a lot of patients complain about that. And in fact, several years ago, the British Medical Journal published a paper in which the doctors in England give sugar pill to all of you in this room. Guess what? 30% of you will complain of muscle pain after you take the sugar pill. And that's what we call not a placebo effect, but called nocebo, N-O-C-E-B-O. And essentially what happens is the more you read about those labels, the more scared you are, the more you think that you're gonna have the side effect, and the more the patients say, oh yeah, I have side effect. And in fact, they were just taking sugar pill. And so that's why I say the actual incidence in the literature, if you Google online, you might say, oh, 20%, but the actual number is about 5%. And the numbers that we really care about, in which it causes your muscle to basically, the muscle cells to die, something what we call rhabdomyolysis, very, very rare as well. I probably only seen it once in my whole 25-year career as a cardiologist. Yeah, so that's why I say typically you don't have to worry about it. Yeah.
And then how about wearables? I had a couple of night incidents of AFib, rapid heart rate, a couple of years ago, and I was wearing an analog watch. And so I bought a smartwatch to track my heart rate at night. What are your thoughts on wearables and the associated apps that go with them?
Yeah, so I'm a believer that the technology advance, and as the technology advance, we as doctors and you as patients and me as a patient, we need to catch up with the technology. Just to give you a reference, for example, back in 1924, I mentioned 1924 because this year happens to be American Heart Association's 100th anniversary, and we're celebrating our anniversary at the Drake Hotel in Chicago. And I think for those of you who don't know about the AHA, be involved. The AHA, I just digress a little bit. AHA is a fantastic organization. Each year we raise about $1 billion, and we give out almost $200 million of funding to do research. It is the second largest funder of cardiovascular research in the US behind the NIH. But I mentioned 1924. Back in 1924, when you get a heart attack, what did the doctors do? You go to the hospital, you lie in the bed, and after 1 week, 2 weeks, if you make it out of there, you get a pat on the back. If you die in the hospital, it's just a tough luck. Fast forward 100 years to today, think about all this stuff. Some of you are heart patients, right? Pacemaker, the TAVR, what the surgeons can do, all the medication that we can give to cut down your atrial fibrillation, your cholesterol, your hypertension, your diabetes, everything, that's all based on advances in biomedical research. And so wearable device is one of those advances in biomedical research. Some of you may have had Holter before, like you wear for 2 weeks to see what your cardiac arrhythmia is. Think about these Holters, and now people are able to shrink into the size of a watch and the size of one of those rings that you wear. And so in the future, I do think that doctors will need to be more educated and actually educated from patients. A lot of times I have patients coming in with these gadgets that I haven't seen before, but they show me these data, and the data is actually very interesting. And so the difference now is before. 20 years ago, when I was a cardiologist, I showed up at Stanford, I talked to the patient. The patient give me their subjective feelings and say, hey, doc, I have palpitation. But then I'm trying to figure out, well, what exactly do you mean by palpitation? It's very subjective. And I have to order a test, like a Holter, to get the objective data from you before I make an action. Right now, it's reverse. You come to the clinic with your objective data and say, hey, doc, I have palpitation. And I say, what do you mean palpitation? And they say, hey, doc, look, all this tracings. I look at it, well, it's indeed atrial fibrillation. Yeah, we got to treat it. So that's the difference. And you will see a lot of advances in wearable devices, and Stanford Cardiology is one of the places that are making these advances. Paul Wang at Stanford, one of our cardiologists, received a big grant from the American Heart Association to look at these wearable devices. Yeah.
Great. Dr. Wu, this is all super helpful. Thank you again so much. There's been a lot of news about diabetes and weight loss medications and how they actually might help with heart health. Could you just comment on Wegovy, Ozempic, and metformin?
Yeah, so I'm sure all of you have heard about Wegovy, and it's a weight loss medication, and it's probably one of the hottest drugs out there. And just to give you a sense, Wegovy is made by Novo Nordisk. And Novo Nordisk last year was the company, is a drug company based in Denmark. And it was the company, Novo Nordisk, was worth $450 billion. The whole GDP of Denmark was $420 billion. And that just tells you how much interest, excitement there is with these drugs. Essentially, these drugs are what we call a GLP-1 agonist. It's a drug that binds to a receptor in your gut. And it tells you, there's several functions. Number one, it tells your brain your brain feels like after you eat something is full. And it also slows down your gut, and basically there's more food here. You also feel like you're full. It also increases the insulin secretion to get the glucose down. It cuts down the glucagon. Glucagon is a hormone that increases the glucose. A lot of actions in terms of how it works, but the reality is that a lot of patients on these medications because cutting down your weight by 10%, 20% has a dramatic improvement on your cardiovascular health. And so last year at the AHA meeting, there was a big publication involving about 17,000 patients in about 40 countries, showing that if you take this drug, semaglutide, in patients who have previous heart attack, previous stroke, or previous peripheral artery disease, you take it for 3 years, it can cut down your risk of recurrence of having heart attack, stroke, or peripheral artery disease by 20%. Now, when you think about it, it makes a lot of sense, right? And the analogy I like to give to my patients is, pretend you own a pickup truck, and you put a 1,000-pound rock on the back of the pickup truck, a 1,000-pound rock, and the truck's engine is revving in a high RPM because it's very heavy. The struts of the frame of the car is under stress. The tires are under stress. All the electronics are under stress. In the past, we as cardiologists, we tried to say, well, okay, we're going to fix a tire. We're going to fix the engine. We're going to fix the frame. But what is the main problem? The rock. And so if you have a way to go from a 1,000-pound rock down to 700 pounds, down to 500 pounds, a lot of the problems that the patient's experience goes away. And that's why it has such a dramatic effect. Yeah.
Okay. Dr. Wu has actually done some experiments in space, on the space station, which I was thrilled to hear about. I think one even stayed up there for almost a year. Having spent a couple months in space, I'd be curious, why are you sending those experiments into space, and what do you hope to learn from them for the future?
Yeah, so I think Steve, at the beginning, I started off by saying I idolize Steve because Steve took the job that I wanted when I was a kid. But I started wearing glasses when I was 80 years old. My dad told me that there's no chance you're going to be a fighter pilot, no chance you're going to be an astronaut. So I turned to medicine instead. So I've always had a dream that one day in the future, humans will be traveling in space. And so when you travel in space, the three major issues, I think as Steve knows quite well, from a medicine standpoint, the three major issues that we need to solve is radiation. There's a lot of cosmic radiation to the body. The second issue is the effect of microgravity. On Earth, there's gravity, and that's why the bone grows, there's muscle growth. But on Earth, on the International Space Station, it's microgravity. And then the third one is chronic hibernation, meaning that if you want to go from one planet to another planet, and it takes you 20 years, well, there's not that many 20 years you have in your life to be able to travel around space. we can't, question number 3, we haven't been able to address. Question 1 and 2, my lab is addressing that. So what we do is we take your blood, and from your blood, we generate something called iPS cells. It's an induced pluripotent stem cells. And from these iPS cells, we then differentiate to your heart cells. So I repeat that again. We take your blood, and 2 months later, you can come back to our lab, you'll see your heart cells there. And so back in 2016, we sent up these heart cells to space, and they came back after 6 weeks. We noticed there's something wrong with these heart cells, probably because of a combination of microgravity and radiation. And so back in 2020, we sent up what we call the engineered heart tissues. It's essentially a chunk of, lack of a better word, chunk of meat, your heart meat, heart muscle. And it came back, and we also saw some abnormalities. Again, our suspicion is that the microgravity and space radiation has effect. And so we went back to the lab to screen for medications that can mitigate the adverse effect on the heart muscles. And so just last year, my team, we went to the Kennedy Space Station to witness the launch, Falcon 9, and we sent 4,000 organoids, cardiac organoids. Half of them were treated with the drug, the other half, they were up there for about 8 weeks, and then they came back. So we're analyzing the data to see if the drug works or not.
Fantastic.
Yeah.
Well, I'm sorry your childhood dream to be an astronaut didn't come true, but there are millions of people around the world who are going to benefit from your work. So thank you. I'm so sorry, though, but we'll have to talk more about it. Okay, so now we're going to go to the Q&A. And so just remember that you can send them in via the QR code that's in your program. And for those of you online, you can use the one that's in the program. Okay, how important is it to treat small vessels blockage? My heart scan reveals mild calcium plaque.
Yeah, so that's a very common question that we get asked as a cardiologist. A lot of times you get these heart scans, it shows some plaques are here and there. And as I mentioned, I give you the analogy of piping system, plumbing system. As we get older, you're gonna see a whole bunch of stuff on your plumbing, right? That's likewise in the coronary arteries, you're gonna see those. Usually we leave them alone. We don't try to put a stent in. We ask you to change your lifestyle. We ask you to take, for example, a statin to get, to basically shrink that plaque or make that plaque tougher so that it doesn't break off. The reason why we don't always put a stent is that when we put a stent in, we are committing you to another drug that could cause you to have a higher incidence of bleeding. And also the stent sometimes clogged up as well. And that's why if you have these mild blockages, we just leave you alone and just say, take medications, exercise daily. Yeah.
Great. On my phone, I have an app that tells me the quality of my sleep. And I noticed the score that it gives me, I can control 3 of the 4 parameters. But the 4th one is called heart rate variability, HRV. Can you just tell us what that is?
Yeah.
It's important, and is there anything we can do about it?
Yeah, so the heart rate variability just refers to how much variability there is in your heart. And sometimes, let's say, for example, one example is when you undergo a stress test and your heart rate shoots up, and as soon as you finish a stress test, your heart rate will come down. And based on how fast it goes up, based on how fast it comes down, a lot of times we can also gauge how fit you are. But in terms of the heart rate variability, our advice is that exercise. I think exercise is probably the panacea for many diseases out there. Essentially, you can become more fit, and your body is able to regulate just the right amount of heart rate that's needed for a certain task. Yeah.
Is there something, sometimes the HRV will vary day to day quite dramatically.
Yeah.
Is there something that potentially I did during the day that made that worse, or is it something that you just don't have control over, or is it stress? Or?
I think, stress is one common factor under HRV, but, there's other conditions. For example, if you have hypertension, if you have other medical conditions, it could also affect your HRV as well.
Okay.
Yeah.
Great, thank you. Our next question is, what if your blood pressure, sugar, and cholesterol are in control, but your BMI is above 30? Are you still at risk for heart disease?
Yeah, so that's, I think, first of all, kudos if your sugar and cholesterol are well controlled. And we understand that, our body mass index is not a perfect science, meaning that usually the BMI for one person may not fit another person. Some people are just stockier, and therefore the BMI is fine. And a lot of times we look at how much central adiposity that you have. But I think in general, if your BMI is under 30, that's probably on the high side, and that we would still recommend you to cut down your weight. As I mentioned earlier, overweight is between BMI 25 to 30. Obese is 30 and above, right? And so at 30, we would still recommend try to get it down to 27, 28 level. Yeah.
Great. Could you explain what metabolic syndrome is? Because our question here is, I've got it, metabolic syndrome. Is there anything I can do to correct it?
Yeah.
Does it increase my risk of heart disease?
So metabolic syndrome, in fact, I almost had it 10 years ago. What I told you when I started to, do something about my health, because my mom had a metabolic syndrome. A metabolic syndrome is essentially a conglomeration of, say, high cholesterol, obesity or overweight, and slightly diabetic. HbA1c may be 6.1, 6.2, and it's essentially a precursor for being diabetic. And so if you have metabolic syndrome, I would suggest you, again, exercise, lose weight. If you have high blood pressure, take medications, high cholesterol, take medications. The AHA, we put up a guideline this year. It's called the cardiometabolic kidney syndrome, or CMK. And it's for the first time, we trying to raise the awareness to the public that your cardiac, your metabolic, and your kidney are all connected. And so you want to take care of all these three major issues. And so this is something that our patients should be aware of, that's metabolic syndrome. And in fact, Stanford is actually one of the very first site who came up with this cardiometabolic syndrome. The late Jerry Reaven was the one who came up with that term. And so if you're interested in this here, we do a lot of research here at Stanford on the cardiometabolic syndrome.
Great. Oh, yes, this is one of our favorites, even discussing with our friends and family. I like to have a glass of wine or a cocktail after work. Is that bad for my heart?
I think it's fine. I think it's fine because I realize all of us need, I think having this social interaction and it's networking and engaging with other people is fine. But I tell my patients that if you're drinking, cut it down. If you're not drinking, do not start thinking that it has a cardiovascular benefit. Do not start thinking that it has cardiovascular benefit because and I'll just spend a couple minutes explaining this. When I was a fellow a long time ago, the researchers came out and said, oh yeah, 2 glasses of wine is good for your heart. 1 glass is no good. 3 glasses is no good. 2.5 is no good, but 2 glasses is good, right? And essentially, these are just epidemiology association studies. These are not what we would call hardcore basic research studies. Alcohol essentially is a toxin. When you drink alcohol, your alcohol gets broken down to acetaldehyde. Acetaldehyde is a toxin. And the more you drink, the more acetaldehyde you have, the more this toxin causes a whole bunch of damage to your body. In the case of a cardiology patient, if you drink a lot of alcohol, you're going to have atrial fibrillation. If you drink a lot of alcohol, you could have what we call alcoholic cardiomyopathy. This acetaldehyde gets broken down to acetic acid, which is non-toxic. In the body, the enzyme that's needed to do that is something called acetaldehyde dehydrogenase. Most of you guys have that enzyme. You could break it down. I just happen to be the unlucky one. About 35% of East Asians are missing the enzyme. So when I drink alcohol, my face flush, And within 20, 30 minutes, my heart rate goes from 50 up to 130, and you stay up there for about 30 minutes before it comes down. So that's why I say that in my opinion, there's zero benefit of alcohol for your cardiovascular health. But notice I preface it by saying if you want to drink a glass in a social occasion, it's completely fine. But just don't think of, hey, doc, I'm drinking 2 glasses of wine every day because somebody told me it's good for your heart. I don't think, yeah.
Let's see, our next question is, I smoked for 20 years, but quit a few years ago. Is my heart still at risk?
Yeah, that's a very good question. I think if you're a smoker, definitely quit. Because if you're smoking, the nicotine in the smoke and also the tar products and a whole bunch of carcinogen products, when it gets inhaled, it causes lung cancer, as you all know. But those carcinogenic products, when it goes into your bloodstream, causes inflammation. And these inflammation, earlier I talked about the pipe and the plumbing and the clogged up. If you have more inflammation into the pipe, it's going to clog up even more. You're going to have a higher chance of getting a heart attack. So it turns out people have done research that if you quit for about 2 to 3 years, that inflammation essentially comes back down to normal compared to a healthy person. And so don't think of it as I smoked 40 years, and even if I quit, it's going to have zero benefit. That's completely wrong. If you quit, you will see immediate benefit after 2 to 3 years. Essentially, the inflammation is the same as a normal individual. Yeah.
One of the common themes that keeps coming up is about sleep, and all of our speakers today have talked about that.
Yeah.
So here's one question. Can uncontrolled sleep apnea weaken the heart?
Yeah, so that's a very important question. I think a lot of us have sleep apnea. I have sleep apnea. My wife goes like this all the time. And that's why sometimes she refuses to sleep with me because I was snoring too much. But essentially, if you have sleep apnea, you're going to have increased hypertension, increased chance of heart disease, and a whole bunch of other medical issues that are generated from having sleep apnea. So I would definitely encourage you to see sleep doctors. And luckily, Stanford has outstanding sleep doctors. A lot of the similar research in sleep apnea was actually done here. And so definitely get it treated. In the past, and it's okay for me to talk about it. 10 years ago, I went to get a CPAP, a night study, a sleep study. Then I couldn't fall asleep at all because there was so many stuff that's hooked to you. I'm not sure how many of you have had a sleep study done. Very, very difficult study. But we talk about wearable devices, right? There are a lot of wearable devices and actually can monitor your sleep pattern. And you can show that data to your doctor. Your doctor looks at it, okay, well, we're going to take some actions, and there's different types of actions people could do, including some kind of chin guard that adjusts the shape of your mouth, and also giving you CPAP, the continuous flow oxygen. And also, if it's very, very severe apnea, the doctor will also recommend surgery as well. Yeah.
Okay. The next question is, I developed high blood pressure during my first pregnancy. Does that put me at risk for heart problems later in life?
Yeah. So a lot of people have what we call preeclampsia, in which during pregnancy you develop hypertension. And that is considered a risk factor for developing later on hypertension in your life. We don't know the exact genetic mechanism behind that. There's a lot of research that's been done here. Virginia Wynn at Stanford is doing, at OBGYN is doing a lot of this research, but it is considered a risk factor. Yeah.
Fantastic. And then how about fish oil?
Fish oil. Who's taking fish oil here? I want to see you raise my hand. Okay.
Do you take fish oil?
I don't take fish oil.
Okay.
Yeah, I take statin, but okay. So let me give you the story about the fish oil. About 4 years ago, there was a study. We call it Reduce It. And basically, it's sponsored by a drug company and showed that taking fish oil in patients who have already cardiovascular disease can cut down the risk of having a heart attack. And that was very well publicized. 2 years ago, in our field, we have another big study, even bigger study. And for that study, we didn't see anything. There's no difference. It doesn't do much at all. And so it's not clear what's the difference between the two studies. It could be that, which is what most of us, including myself, suspect, the initial study that showed fish oil has a positive effect. It's basically the control group, meaning the placebo group. Half of you get fish oil, the other half get a placebo, and the placebo is actually mineral oil. And they found that the mineral oil, when you take it, when you draw the blood, it increases your inflammation. And it's possible that the control group got worse, and therefore it made the treatment group look better. And so that's why the second study that was done, we didn't see much. And so it's quite controversial. I don't tell my patients to take fish oil. The main reason is that if you already have coronary artery disease, statin. I told you statin should be in the water. I mean, I would just ask you to take statin, jack up on the dose of a statin. A lot of times patients are underdosed, and that's a much, much better drug to get your LDL down, to get your triglyceride down. Yeah.
Thank you for your continued actionable advice. This is so valuable to our attendees. Could you explain what cortisol is? And this person wrote, I've heard that high cortisol levels increase your risk of heart disease. What can we do to lower our levels of cortisol?
Yeah.
Can cortisol levels be tested?
Yeah. So cortisols are considered, basically these are hormones in your body. So if you're under some kind of stress, your cortisol shoots up. If you're exercising, your cortisol shoots up. Essentially, hormones, stress hormones. And if you're under a lot of stress, chronic stress, these cortisols causes inflammation. Again, getting back to the plumbing analogy, it causes inflammation, it causes plaque rupture, and therefore if you have a lot of cortisol chronically over a long period of time, it's bad for your heart. In a very short period of time, cortisol is good for you because, for example, if you're fighting a cold, you need your body to be revved up. If you're exercising, you need your body to be revved up. If you see a lion charging at you, you need cortisol to be pumped so that you can run. Acutely, it's fine, but having it chronically for a long period of time, it can cause damage to your body. Yeah.
Okay, great, thank you. My wife and I were having a discussion with our children recently about CPR, and they had both recently learned it again. And I was surprised to hear that we don't give the rescue breaths anymore. Why is the hands-only CPR now the norm?
Yeah, so that's a very important question, and we look into this at the AHA. And so here's the thing. Let's say, for example, you find somebody, a complete stranger that's down. How many of you will feel no qualms, completely comfortable going there and give it mouth-to-mouth?
Hey, there's another one.
I see a lot of people shaking their head. And that's the issue that we deal with, that the guideline says 30 chest compression to breath, 30 chest compressions to breath. But then if you see somebody down here and you say, well, I'm not sure if I want to do the mouth-to-mouth because I don't know that person. While you're thinking, the clock is ticking, important time is being passed. And so if you stop, let's say, for example, your heart stops pumping blood to the brain. Within 20 seconds, you're passed out completely, right? Within 3 minutes, your brain is starting to die. Within about 7 to 8 minutes, you're gonna have very, very severe damage. And within about 10, 12 minutes, most of the time, the patients don't make it. So think about that. Patient just found down. It's taking you like 2 minutes and say, hey, should I do it or should I not do it? Because of that issue, we just decided to change our guidelines and say, go in and start doing the chest compression, because for a couple reasons, you need that heart to pump to get the blood to the brain. And even if the person stopped breathing, there's still enough oxygen content in the blood. So you need the blood to keep going. And if you stop, you basically interrupt the flow to the brain. In fact, there are studies that showing that if you do a chest compression only versus chest compression, 30 compression to breath, it's just as good, if not better. And when you think about it, it's mainly because of this. When you're doing chest compression, the blood is going to the brain, and when you stop, there's no blood going to the brain while you're giving that true breath, and it takes you another 10 seconds to go back to the chest compression, right? And so that's the reason. Now, this is for the general public. We just recommend chest compression. But let's say, for example, hypothetically, my wife find me down on the floor. Well, she should be doing chest compression, and my son should be giving mouth-to-mouth breathing. It's the best scenario at the same time. But again, for the general public, the recommendation is chest compression. For the EMT, chest compression plus breath. Yeah.
Well, thank you for that clear explanation. I was hoping we'd come back to diet. This person asked low carb, high protein, low fat, low carb, high protein, low fat, intermittent fasting. Which of these diets are good for heart health and are some harmful? Low carb, high protein.
I think at Stanford we have one of the world's expert. I'm not sure if Chris Garner is still here. He's the real expert on what type of diet is best for you. But I would say in general it's all moderation, right? Just it's all moderation. I tend to eat in moderation, and when I go out to restaurant, even though I'm a cardiologist, my wife knows. My favorite dish is what? Hamburger, right? But I don't eat hamburger every day, right? I don't eat hamburger. It's all moderation. So if you moderate your diet, I think it's okay. And then in general, we recommend the Mediterranean diet to everybody, right? But I can tell you that usually I tell my patients, there's a couple things I tell my patients, I emphasize to my patients. Avoid anything that has sugar in it, sugary beverage, right? For example, I told you about 10 years ago when I started to change my lifestyle. 10 years ago, I used to drink one big glass of orange juice, breakfast, lunch, dinner. Now, actually, I look at the carton, it says one glass is about 300 calories. So that's almost 1,000 calories right there in a day, right? And so 10 years ago, I drank Coca-Cola. And when you look at it, there's a lot of sugar there, right? So the simplest thing I actually tell my patients, and I discuss this, I just tell them the same thing, moderation. You can eat whatever you want, but with moderation. But the only thing I ask you to do is cut down anything that has sugar beverage in it. No orange juice, no apple juice, no Coca-Cola, no Pepsi, and water, coffee. I think Dr. Long will say coffee is good. Tea and milk, low-fat milk, because it has calcium in it. It's good for your body. I think if you take that simple act, for most of you here, you could easily cut off about 500 calories that you don't need in your body. Yeah.
I think having such a transparent speaker is just super helpful for all of us. So thank you for being continuing to be so transparent.
Thank you.
So you don't recommend taking fish oil, but are there supplements you would recommend?
Yeah.
Vitamin D as in Delta,
Yeah.
K as in kilo, or CoQ10,
Okay.
magnesium or calcium?
Okay. So in general, these are all vitamins, right? These are all also essential nutrients in our body. In general, what do you eat in your diet will cover most of those vitamins. What do you eat in your diet will cover most. And I assume we live in Palo Alto. Most of us should be able to have a diet that covers most of these nutrients. It's very different. For example, if you're homeless or alcoholic and you have chronic nutritional deficiency. Also, I talk about moderation, not just for food, but moderation for some of these levels in our body, meaning the levels means your level of calcium, your level of potassium, your level of sodium, your level of magnesium. Our body has a homeostasis, right? Too low is bad, too high is bad, right? Too low of potassium is very bad, you can die. Too high of potassium is also very bad. Actually, in fact, in the research studies, how we anesthetize and how we kill animals is by giving a lot of potassium. Same thing. Too low calcium, too high calcium is bad. And so a lot of these right here, if you're taking like 1,000 milligram supplement of this, 1,000 supplement. I don't really see there's a much beneficial effect of taking all these supplements. If you were to take one, the only one that I just recommend to my patients is just take Stertzer, which is a multivitamin. I take it myself, and it covers most of it. But you don't need to take an extra or 2 or 3 or 4 that boosts your level of these vitamins to 1,000-fold or 500-fold. I think it's just way too much. Your body just dumps them out. And most importantly, if you stop doing that, you save some money. Yeah.
More incredible advice. Again, thank you so much. I have my multivitamin and 3 or 4 other ones, so I'm going to go home and empty the medicine cabinet. Last question. Is it too late at the age of 76 to start losing weight and exercising?
No, there's no such thing as being too late at age 76. I think all of us are living longer and longer, and I think at age 76, if you start to lose weight and exercise, if you do that, I guarantee you it's going to add several years into longevity. There are a lot of people, a lot of companies, startup companies, and want to come up with the longevity drug, as you all know. In my lab, we're developing medications that could also increase the longevity. We also want to do that. But when you think about it, the best way to cut down, the best way to increase your lifespan is exercise, because exercise cuts down inflammation. Inflammation is bad, and we know inflammation causes accelerated aging, causes heart disease, causes stroke, causes a whole bunch of stuff. And how do you cut down inflammation? How do you cut down inflammation? The best way to cut down inflammation is exercise and lose weight, right? Other medications that we give you have side effects and have other issues, but the natural way to cut down inflammation in your body, exercise and lose weight. Yeah.
Great, thank you. Well, before we collectively thank Dr. Wu, let me just say again on behalf of the staff and Dr. Wu, we're so thankful that you decided to spend time here today. Please tell your friends so that next year we can reach more people. Dr. Wu, the take-home value from this 50 minutes has been huge. And so we're all so grateful you're changing people's lives.
Yeah.
So thank you very much.
Yeah. Yeah.